webinar, Implementing Team Huddles. Home implementation. This webinar is the first free installment 2000 how-to webinar series titled Fostering Partnerships and Teamwork in the Pediatric Medical Home. This educational webinar series is presented by the National Center for Medical Home Implementation, a cooperative agreement between the American Academy of Pediatrics and the Maternal and Child Health Bureau. Before our faculty begin, I'd like to inform you of some housekeeping items. The slides will appear in the central window of your screen and will advance automatically. We encourage you to ask questions throughout the presentation using the question box window on the right-hand side of your screen. Please include your state or organization with your question so that we know who you are. These questions will be answered at the end of the presentation. If we do not have time to answer your questions during the webinar, we will send you an answer directly via email at a later time. This webinar will be recorded and archived on the National Center for Medical Home Implementation website approximately 1 week after this presentation. After the webinar, you will also receive an email with a link to the webinar evaluation survey. We encourage you to complete this evaluation so that we can continue to improve the content and manner of our presentations in the future. I'm honored to introduce you today to today's moderator and faculty, which include Dr. Christopher Stilla, Dr. Lester Hartman, and Courtney Nelson. Dr. Christopher Stilla is a member of the National Center for Medical Home Implementation Project Advisory Committee. He has worked in both community and academic pediatric settings, children and youth with special healthcare needs in the medical home. Dr. Lester Hartman is a senior associate at Westwood Mansfield Pediatrics, a private pediatric practice in Massachusetts. His practice has been a certified medical home for over 5 years. Dr. Hartman and his practice specialize in self-management and patient empowerment. Courtney Nelson is a registered nurse and received her Bachelor's of Science in Nursing from St. Joseph's College of Maine. She is the nurse manager for the Westwood location of the Westwood Mansfield Pediatrics office and works closely with Dr. Hartman. The presenters have no financial or conflict of interest disclosures to announce. And with that, I will hand it over to Dr. Stilla.
Great, thanks very much, Alex. And thanks for having me on this. I think just a little bit of my own background and from a practice standpoint is I help to oversee 2 academic practices. One is a very busy urban primary care practice for the underserved, and the other is a complex care practice where we do both primary care and consultative care. And we do a lot of quality improvement initiatives within those. And you might imagine that in a large academic practice, doing QI type things is sort of like driving a great big ship. The thing about Huddles is it's really quite easy to implement in most settings, and it's an incredibly value-added thing for a little bit of effort. I think it has a big role in changing culture as well as improving patient safety. So those are both kind of 2 important things. We'll talk about this vignette real quick. I'm sure many of you are familiar with it who have been in practice as a clinician. So it's 3:15 p.m. on a Tuesday, and patients are starting to back up, as they often do. The nurse on your team stops you between patients to tell you that your 245 patient with autism is starting to get really cranky because he doesn't like to wait in the exam room. She also tells you that you need to reorder different shots for your patient who you just saw at 2:30 because of that vaccine shortage that keeps going that we're all familiar with. So you try and hurry to your 245 patient, and then the MA on your team tells you just as you're opening the door that she has to leave early because of her kid's school play that she told you about last week, and you said okay. Then you also see that your 3 p.m. patient with special needs is only booked for a 15-minute visit. So before your blood pressure goes too much higher, I'll ask for the next slide. So what choices do you have? Well, your first impulse is probably to run faster, whether it's into the exam room or maybe away. The second is to behave badly and have a temper tantrum. The third might be to get a colleague to see one of your patients, maybe a little bit more functional. The fourth is just to keep on slugging right along and going as fast as you can. And then the last one might be that next time you will try and prevent all this, or at least mitigate it with a team huddle, which is actually possible. Okay, next slide, please. So this brings up the objectives of what Lester and I would like to talk about. We believe that by the end, you'll be able to, certainly to define team huddle and explain why it's so effective as part of an overall team-based approach to providing care. You should be able to describe a few strategies that you can use to implement huddles in your own practice, and then provide examples for some of the naysayers and skeptics in your own practice about successful implementation in specifically Lester's practice. Next slide, please. I think a couple of things that we assume is that you are interested in providing a team-based approach to care. Otherwise, you probably wouldn't be on this webinar. But maybe having some difficulty or interest in implementing it in the best way. We believe that huddles are a very easy strategy to help the team-based approach and help to change the culture toward a team-based approach within a medical home. Next slide, please. So what are huddles? They're regularly scheduled meetings, typically short, sometimes very short, for a practice team. Whether there are different kinds of huddles that we'll learn about. Bigger huddles where the entire practice's team might meet, smaller ones where it might just be one clinician and the support staff connected to that clinician for that session. The goals of huddles are pretty simple. Overall, to improve the ability of team members to work together and also to enhance the quality of patient care. And the great thing is you can often see that within one or two huddles right at the beginning. There are different levels of huddles. You can have longer ones. You can have shorter ones. Most practices work well with a combination. Next slide, please. Obviously, the first benefit of the huddle is communication that may not always routinely happen if you don't get together and talk with one another about the day or what you're expecting. One thing that is important to work on while designing huddles and implementing them is that participation of every team member is really important. You can plan for changes, whether it's short-term changes like your patient that's coming in 15 minutes or longer-term changes such as flu season that's coming up. Foresight kind of goes along with the ability to plan for changes. You can improve the organization of either your little team or your whole practice. Patient outcomes, care coordination, being able to tell families that you're listening to their needs and that you see them on time. Most team members really feel like huddles can provide an enhanced environment to work in through better communication and more respect for one another. Patients and families and staff can help when things run on time and more efficiently. And then finally, I've already referred to culture a couple of times. Okay, next slide. So to start a huddle, you need to discuss the idea with staff and providers, making sure that everyone understands that it's safe to talk about things in a huddle and that everyone's opinion and input will be respected. To highlight the benefits that we talked about on the last slide, depending on what meetings and other things your practice has already, the scheduling may vary depending on the needs of your practice. A huddle, a large-ish huddle might be able to be implemented within your regularly scheduled provider and staff meetings, depending on what you already do. The other thing is team members need to be aware, especially not if you're just starting huddles in general, but about a specific huddle. Okay, it's 1:05 p.m. We're all going to get together for 3 minutes and talk about the kids that we're going to see this afternoon. Stuff like that. Next slide, please. Huddles should be very limited. 15 minutes is sometimes really long, actually. Most of the day-to-day huddles that we have are more like 3 or 4 minutes, especially once they start getting going and people know what the routine is. You should choose a central location, whether it's the few exam rooms that you may be working in or if it's a larger huddle, if you have a conference room or maybe a kitchen or break room where people tend to congregate. The first few times, you probably want to create expectations and objectives, although those tend to be more implicit as time goes on and you get to make your huddles quicker. You should probably have someone take notes for somebody who's other people who aren't there, or maybe if people are in exam rooms seeing patients or checking patients in. Most of the time the leader is the clinician, although not always. Some of the huddles that we do are often led by the nurse. If there's any supporting documents like a schedule people need to refer to, it's good to have a couple copies there. Sometimes there's follow-ups from previous work that you need to do. And as I mentioned before, the schedule is often helpful. Okay, next slide. Not sure if we are up to Dr. Hartman's slides yet or not. I just don't want to step on his slides.
No, not yet. Dr. Hartman coming up.
Oh, okay, great. Good. So the biggest thing, I think, on the micro huddles that I think is useful is to talk about patients that require more time and more assistance. For example, the patient with autism in the vignette who might need to be seen a little bit sooner and take a little bit longer. It can prevent a backlog, assuming that the rest of your schedule is organized reasonably well. One thing might be also to help with the backlog is what openings can you fill? If someone is just canceled, you might be able to fill that. It's also important to talk about people who you know on your schedule might not come or might be late and how to plan around them. If there are any scheduling issues, such as the staff member in the vignette that needed to leave early for family reasons, that's important to talk about. In bigger huddles, you may want to talk about patient flow and any sort of issues with that or problems that you're having. Sometimes, we don't typically do this because we do it in another forum, but you might want to talk about results of consults or lab tests that are going to be for the patients that you're planning to see in the course of an afternoon. And then if there's any vaccine issues. Many places, many states have separate supplies of vaccine for VFC patients and patients with insurance and different shortages that come and go. And so frequently on a weekly basis, there's some disruption to your usual vaccine schedule. And knowing about that and preparing for that, that can really save you time, again, as we talked about in the vignette. Next slide, please. Okay, now it's time for Dr. Hartman and Courtney Nelson, who works with me closely, to take it away with some concrete examples. Thank you.
Chris, thank you very much for that thorough discussion. This is Lester Hartman. I'm the senior pediatrician at Westwood Mansfield Pediatrics, which is a 2-site practice with 11,000 patients, 16 providers, 8 physicians, roughly 8 NPs. I'm stationed predominantly in the Westwood office, so I'm going to be referring specifically to the Westwood office and how we manage things there. Can I have the first slide, please? So, on reflecting on this, I think we have a system of 2 different types of huddles. The first one we call the macro huddle. Obviously, this is a huddle that's when everybody gathers together for a time period. Sometimes we even have something called the macro huddle if we have a 3-day weekend where we get the 2 offices together on the phone so that there can be sign out for over the weekend if there's particular concerns with specific patients. Macro huddles I view as something where you start to standardize care among each other. You know, who has asthma plans that need to be done, and who has other specific types of chronic care, standardized care that we have in written management plans that are going to need to be available for the patients. Typically, ours are, like Chris said, more than 5 minutes off will just oftentimes makes people drift because they're ready to go for their day and they want to get started. Sometimes it's particularly in the Mansfield office when I'm there once a week, we do huddles in the lunchroom so that we can have everybody there at the time. Our huddles are in fact morning, and actually afternoon, and we do some evenings because we're open till 8 o'clock at night. Everybody that's involved is staff, triage. We have the RNs, NPs, MDs. We're soon going to have a therapist involved, and oftentimes we may even have some of the front desk people as well. So in the macro huddle, as I said, we're trying to standardize care. The key is we're trying to get everybody on the same page. I think I'm going to be a little redundant with what Chris said, and my apologies, but we want to know if somebody needs to leave early so there's no surprises for the providers that are there. We want to add additional appointments by the permission of the providers, because even with standardized schedules, there's oftentimes room to add or subtract people during the day as well. And sometimes the triage nurses need the permission of the provider to do that, as they may not be comfortable making that judgment on their own. Again, as Chris said, heads up on specific appointments that may be lasting longer. I think there are additional things, like, for example, when we have meetings, our partner meetings or provider meetings, and we set new policies, this is a good time to communicate with people about policies, because it's not that often. Our offices are big enough now, it's very difficult to get the entire staff together. So oftentimes we do things in the huddles to relay communications among all the staff as well. The other issues, for example, right now, for us, continuing with the flu shots, because as it seems to wane more and more in people's minds, we still want to continue, according to the CDC guidelines, to continue to give flu vaccines to people. So those are the keys, I think, for what we call the macro or regular huddle. Have the next slide, please. Now, the next slide I call the mini huddle, which is more individualization of care, which in the medical home, sometimes I say the word for the medical home is really customized care, and this is where I think in some ways it really does happen. It's where the staff sits one-on-one with the clinician, and they review what needs to be done on each patient, specifically what vaccines. We have a section that looks at different things, strengths and challenges of a particular patient. For example, somebody who's needle phobic, or somebody who's had an award this year, so that we can also prompt when we talk to families that we're aware of their strengths and also of their needs as well. So this is the time when we do it. For example, in the flu vaccine, we may get a flu miss to somebody because they are especially sensitive to needles as well. The California, and I know I'm jumping a bit ahead here, but the California Health Safety Net Institute Embracing Daily Huddles, I believe that's the video that's there. And if you want to look at what I would call a mini huddle for customization, I think that's a great huddle. I think also we give an enormous amount of education material, and we do quite a bit of surveys at the time people come in the office. And one of the big things we do, for example, we have the depression screens, the PH29, the MCHAT, the autism screens. All these different kinds of screens can be extremely confusing to get together at the beginning of a day. So individual huddles, oftentimes we pick up things that may need to be added or subtracted. And with all the developmental screens that are being required, at least in Massachusetts, it's very helpful to have these mini huddles to customize what screening tools that you will be using. And I think that these huddles add an enormous amount of value to improving care in patients in our practice. That's pretty much all I have to say. I don't feel I need to say too much more at this point. I'm going to turn it over to Courtney, our head nurse in Westwood, and she will take it from the nursing perspective. Oftentimes, Courtney in our office here runs the meeting, the huddles that we have. Courtney, can you take it away? Next slide, please. Courtney?
So when I started, yes?
Go ahead, I'm sorry.
When I started at Westwood Pediatrics 4 years ago as a staff nurse, the huddles were already in place. While sometimes sporadic, I really became a big proponent for them. I feel they're invaluable. So now as the nurse manager, I make sure that we do have them daily, twice a day, because they just provide so much value, not only for the patients, but for our nurses. As a nurse, I know, especially on triage, when you look at that morning schedule or afternoon schedule sometimes, it can be really frustrating to see, that maybe we don't have as many appointments as we would like. And so it is really nice in the huddle, we can ask the specific providers, is there any appointments that we could shorten, or, do you need this break here? And they're able to free up time for us, and we really work as a team on the schedule. Also, when it comes to our patients, even though we're working up the patients, we're the one giving the shots or doing the lab work, we don't get to spend as much time with those patients as the nurses, the NPs, or the doctors might. So it's really great for us, especially in the micro huddle, the mini huddles, to be able to ask them, what's this patient like? I'm not as familiar with them. Just so you're prepared and you can tailor your approach with that patient to what they really need. Also, when it comes to morale, I feel like it really sets a nice tone for the day. Every once in a while, we'll tell a joke or two, or tell a story, and it boosts the morale for the whole day, because there are some days where people just feel a little run down, and so it's nice to have that moment to kind of lighten things up, get prepared, get your enthusiasm back, and go forward. And it's also the best place for us to introduce new employees. When we get a new provider or a new nurse, it's nice to be able to bring them in front of everyone and just introduce them. But I feel that they have been invaluable as a nurse, to have that one-on-one communication with your provider as well as the whole team. I think the huddle is the best way to go about that. So next slide, please. And I think Dr. Hartman, I don't know if you want to cover this part.
Thank you, Courtney. That was really a great synopsis. Much appreciated from a nursing perspective. And we think that team huddles are a very effective part of team-based approach to primary care, and that we all feel ownership of families when we do this. And the benefits include improved ability of the clinical team to work together and increased quality of care for the patients as well. As Chris said, sometimes with autistic kids, we'll pull out an iPad and make sure that that's in the room at the time when kids may be bored. Or some of these kids, sometimes when they're in the room, they want to play with some water, and we'll allow them to turn on the sink because we don't have any hot water in it. And that can keep them calm for at least a few minutes at times when we need to be talking to the families. So next slide, please. I think these are great resources from IHI, and again, I mentioned the California Healthcare Safety Net Institute. I feel that was a great, great mini huddle, and as an example of how you can structure those yourselves if you want. The DoD program as well, and I also like the Checklist Manifesto by Atul Gawande. Though it's more surgically oriented, it's a very interesting way about when people get together, how they discuss the plans of things, how they develop checklists. It's in the back of the book, and if you get a chance, I'd recommend you read it. Even though it's from a surgical perspective, it draws on various areas like the military and the airplane industry, so that mistakes don't happen with the daily mundane things that we do, because often the complex things aren't the one where the errors occur, but the more mundane, simple things that we should be doing that happen. And a checklist can significantly reduce our errors that way. I think this is it for me, and I believe, Chris, the rest is yours. Thank you.
Great, thanks, Lester. We will have a lot of time for questions, which is great, and hopefully this fits within your lunch break or whatever time you can take between the morning and the afternoon. I did want to highlight, changing gears a little bit, a couple of other things that the National Center for Medical Home Initiatives will be hosting. There are 2 other video webinars that are going to be happening. One is on care partnership support. The other is on family advisory groups. I think the team huddles and family advisory groups ones can go together really well because it's essentially building relationships within your practice. And a lot of the principles that you use for one can be used for the other. So I'm looking forward to that. Elsa and Alex will have some details about the timing of those. Oh, actually, here they are. Okay. So the first one is just under 4 weeks from today, about enhancing care partnership support on how you can partner, especially with children with special health care needs in your practice. And then the family advisory group is 4 weeks after that. First one is in the early afternoon Central Time. The second one is a little bit earlier. And I believe registration is open for both of those. Be happy to talk about anything else. Other than that, feel free to field your questions, and Elsa and Alex will give you information about how to do that.
Great. Thank you, Dr. Stilla, and thank you, Dr. Hartman and Courtney, for your valuable presentation. We do have some questions, and I will go through them now, but before, I just want to remind all of our audience members that you can ask questions by typing them into the question box that should be on the right-hand side of your screen. I'll start off with some questions that already came in, and I think that Dr. Stilla, Dr. Hartman, and Courtney, all 3 of you, probably have very valuable insight to answer these questions. First question comes from a fairly large practice that sees about 200 patients a day with a 30% no-show rate. And their main question is how to schedule a team huddle in the morning when not all staff is there, and they're seeing patients from 8:30 in the morning to 8 o'clock at night. So there's really no opportunity to have a team huddle during the day. But not all staff are present in the early mornings. So do any of you have any insight on that?
Alex, I'll field this one. This is Chris, because it looks like it's more likely an academic practice, given that there's a lot of residents. Our primary care practice is roughly the same size, although our no-show rate is not quite as high. It's a little harder when not all the team members are present. I think it's important when doing huddles to get as many key team members there as possible, whether it's shuffling schedules around, giving people a few minutes of protected time, something like that. So I think the first step is to try and optimize the scheduling so that the most people can be there. Once you've done that, I think it's really important to take good notes. One of the things that we do, our practice is divided, our primary care practice is divided into 5 pods of 6 exam rooms each to make the practice seem smaller. And essentially the main points of the huddles we just write on a whiteboard each afternoon. The nurse writes, there's room for 4 or 5 sentences on the whiteboard, and that's how we communicate to one another.
Okay, great. Thank you, Dr. Stilla. The next question, I think, would probably be well-suited for Dr. Hartman and Courtney. We have quite a number of people asking how to keep the huddle limited to just 5 minutes. Maybe you could provide some background on Dr. Hartman and Courtney?
I think what we want to do is again, the outline that we use is to get the schedule settled. The priorities are what we look at first. How's the schedule? Are people going to be away? Are there any critical announcements that we have to do? And then at the end, if there's any time left over, we kind of do the light stories and things like that, which we can't always get through. And we just do our best to go through as much as we can in those 5 minutes. The key is trying to get everybody gathered. And sometimes, like in my other office, it's a little slower, so sometimes we just do it in the lunchroom right there, rather than having people gather in the doctor's offices. Here, the structure of the office in Westwood's a little different, so it's easier to get everybody together. All the doctors and nurse practitioners in our office sit together when they're working, so there's not separate offices. And sometimes, facilities have it where physicians have their own separate offices that they go into, or other clinicians. So what we do is we have everybody in the same office. So again, as Chris said before, you have to have a central point to get people there. And if you don't keep it, if you do it for more than 5 minutes, you will lose the attention of people because they're going to be looking at their EMR or looking to see what they need to do with the first patient that comes in. So you really have to tailor it closely when you do it. And that's where I think, for example, the book Checklist Manifesto really does help, looking at how to tailor it so it's brief and quick. Courtney, do you have anything to add?
Yeah, I would have to agree that we do prioritize, and based off of, you know, when patients start arriving, sometimes 1 or 2 nurses may have to leave, but it's really about, like Dr. Stiller kind of said, you know, somebody taking good notes and passing it on is the best way that we are able to accomplish it if someone does have to leave early. But really just prioritizing what's most important right now is the best way to keep it short and sweet.
And I think the kind of rule of thumb is a huddle with some is better than no huddle at all.
Great. Thank you, Dr. Hartman, and thank you, Courtney. Our next question, I think, can be answered by all 3 of our faculty members. It asks, how do you get buy-in from your staff regarding team huddles?
Chris, do you want to go first, or shall I go first?
I think getting buy-in from the non-physician staff, in my experience, has been the easiest, because it's a way for everyone to have a voice in how things run. Getting the physician staff to show up sometimes can be a little bit harder, but I think if you emphasize that it can make their day run smoother and also result in much improved patient quality and satisfaction with a very low amount of effort, then that's good. I think that the biggest thing is scheduling, as we mentioned before, and I think scheduling it really carefully so that as many people can come, and then also just, you know, as a practice leader saying, this is really important, we are doing this. Make it work, you know, with a little bit of an edict once you've made it as convenient as possible.
I agree with Chris. I think the thing about it is sometimes you have to implement it, and then people have to start to learn the value as they watch a huddle. I remember at the beginning the huddles were a little bit smaller because not everybody participated, but when people had things put in their schedules that they weren't happy were put in, they suddenly discovered that there's a value to this, or they didn't know somebody was leaving early that day, so they're ending up doing more sick visits. That really incentivized them because it you know, it's affecting the quality of their lives. So I think that's an important piece of the puzzle as well. Courtney, do you have anything?
Yeah, I would say, you know, from at least the nurse's perspective, it gives you a chance to actually be able to communicate any of your questions to the providers instead of having to catch them on the fly. Having them all in one central location with this is the purpose, you know, you can get your questions answered, really makes the nurses want to participate because nobody wants to have to chase down, you know, one of the doctors or NPs between patients to ask a question. So it really does let them start off their shift on the right foot with the information they need to have a successful shift.
Great. Thank you, Courtney, Dr. Hartman, and Dr. Stilla. To sort of follow up that question, we have another question. It starts off by saying that huddles seem to support resiliency among staff. What tips do you have for developing resiliency as a skill among your clinic staff during times of change or transformation?
I think Courtney and Lester, I'll let you answer that one.
In some ways, that's kind of like, for example, the pep talk. For example, the leader has to be really upbeat. For example, if somebody's sick that day and they're unable to come into the office, then you've got, you know, the load of extra patients for illness, and maybe some of the scheduled visits are going to shift to somebody else. And it's really important to make sure that everybody's aware of that so people can step in at times if they see that somebody's getting behind. Again, that's that whole team-based approach that you need to do. And, you know, there's a saying that says enjoy your achievements as well as your plans. And I think sometimes the huddles are a great place to take a minute to reflect on what people are doing right rather than catching people doing things right rather than catching people doing things wrong. And conversely, there can be a time where you have this discussion about how there was a systems error that led to an error, because sometimes people feel that they were responsible for an error that was really a systems error. And this can be an opportunity to talk about that at times. And again, I think that goes back to what Courtney mentioned about this helps boost the morale for people, and hence, I think boosting morale augments resiliency. Courtney, do you have anything?
Yeah, no, I would agree with you. It really does reinforce the sense of we're a team. You know, any changes or difficulties we're going through, we're going to get through them together. I know in huddles I always like to quote Tim Gunn, for whoever knows who that is, with saying, you know, make it work, we'll get through it. So it really just does reinforce that, you know, whether something great has happened or something difficult's going on, we're a team, you know, we've accomplished it together, or we're going to get through it together. And that's one of my favorite things about the huddles, actually.
Great. Thank you, Courtney, and thank you, Dr. Hartman. We have some other questions that are very specific to team huddles. The first one is, how do you document what happens in a team huddle?
I think it's pretty simple most of the time. Have someone who's willing to take notes and jot down, you know, if it's a 5-minute huddle, there's probably maybe 3 bullet points. If it's a 15-minute huddle, maybe more like 8 or so. You know, usually the most talented note taker is the one who volunteers most of the time.
To be honest, we don't really have, and Courtney, correct me if I'm wrong, we don't really have note-taking at the time. Most of the time people now at this point are all together, because so much of it is having to do with the schedule and putting things into the EMR beforehand. So in a sense, that becomes the note-taking as well. Occasionally, I will sit down before a huddle and reflect on some ideas and put it in on a piece of paper. But I like Chris's idea of the whiteboard in a room. That could be very helpful, and hadn't thought of that. Courtney, do you have any comment?
Yeah, I mean, I would say the same, that we don't have a specific note taker, but if there's something that needs reiterating, or that maybe a couple people missed, I usually will send an inter-office email so that everyone has it. They can refer back to it if there's been, you know, a decision made or something that is really pertinent besides just, you know, you can give me an extra appointment here. If it's something that everyone needs to know about, I will send out an email.
Okay, great. Thank you, Courtney, and thank you, Dr. Stilla and Dr. Hartman. We have one last question. It says, is there anything specific that, besides what was already stated, should be talked about during a huddle pertaining to that particular day?
I think I could answer that some in the sense of, for example, as I mentioned before, particular days, you know, Fridays, for example, are shorter days for us because we're there till 5. And then you have to go into the weekend. And then particularly around 3-day weekend holidays, which New England is known to have a fair amount of, you want to make sure that all the providers each day are kind of ambassadors for the other office as well, because they may not see those patients as often. So you want to just reiterate, okay, who's on this day, who's on that day, so that we know what to expect and who to identify with if we need to communicate something to another provider. And I believe that's done through nurse triage, you know, the EMR, and nurse, Westwood nurse and nurse Mansfield is the category where nurses leave information through the weekend. It also gives the opportunity to say have a good weekend and also have a good holiday. So I think that, you know, these are these are things that I think are valuable. Mondays, you certainly are looking at being busier days, and oftentimes you may have fewer scheduled visits and expecting more illness visits at the time. So there will be a little different mindset on that as well. And sometimes people on Mondays will change a visit from a 20-minute visit to a 10-minute visit in order to fit more in if the schedule's just getting tighter and tighter. I hope that answers the question. Any comments, Courtney or Chris?
Yeah. We were just saying more specific things that we discuss. Obviously, in most places, you know, the doctors and the NPs, each one is very individualized with their own idiosyncrasies, how they like things done. So especially with the mini huddle, you know, you're able to get from one provider might like one kind of workup, while another provider for the same patient might want something else. So it's very nice to go through and specifically talk patient to patient. What vaccines do they need? You know, do you want, you know, a specific test for them while they're here? Are there special things I should know about the patient when, you know, working with them and approaching them? So I think that mini huddle especially, those are some of the more specific things we discuss.
And thanks, Courtney and Lester. The only thing I might add to that, Lester, you already, I think, alluded to it a little bit, is if there are lab tests or x-rays or anything that's likely, especially on a Friday, to need follow-up over the next 24 hours, one thing that we've discovered is it's useful for the nurses to hear that as well as the doctors, in case somebody forgets or in case that, you know, they hear something in passing about, you know, oh, this kid's, you know, urine had an infection or something. So that can be useful to monitor as part of a huddle, especially if you have a practice with more kids with special health care needs than your average practice, because there tends to be more stuff to follow up.
Great. Thank you, everybody. I want to thank our audience members for submitting questions. There are still more questions, but we're running out of time. So those questions that were unanswered during this webinar, we will answer them individually through email to the person that asked the question. I want to thank again our moderator and our faculty members, Dr. Stilla, Dr. Hartman, and Courtney. We really appreciate you taking your time to share your experiences and your expertise with us. For our audience members, this webinar will be recorded and posted approximately 1 week after today on our National Center for Medical Home Implementation website, along with a speaker notes. Additionally, you will receive an email after this webinar shortly. We will be asking you to complete an evaluation survey, which will only take a few minutes of your time. We would greatly appreciate it if we could get your feedback. Finally, registration for our second and third webinars in this series is now open. The second webinar is titled scheduled for Thursday, March 27th at 1 p.m. Central Time. The third webinar is titled Starting and Supporting Family Advisory Groups, and it is scheduled for Thursday, April 24th at 11 a.m. Central Time. So thank you again for your participation, and we look forward to seeing you next month.
Thanks, everybody.
Thank you.